So good evening, everybody. It's my pleasure to talk to the learned people on PCOS. Who could teach us better than the endocrinologists on PCOS? And we have had a lot of interaction, at least in Hinduja. I'm so happy that we work so well together, the endocrinologist and the dermatologist. And today I'm going to talk to you about the dermatological manifestations of PCOS, maybe giving you little insights of how our mind thinks. So we know that polycystic ovarian syndrome is the most common endocrine disorder amongst the reproductive age women, and it spans several decades of their life and entails several health risks. It impairs mostly their quality of life, and especially when we see it in adolescents who already are so prone to depression and anxiety disorders, it plays a big role in their psyche. You'll all know what polycystic ovarian syndrome entails. So you have the cutaneous and you have your gynec disorders and you have your endocrine disorders, and we all work together in such patients. So when do PCOS patients come to us? What do they come to us for? A lot of time, the patients who come to us have not yet been diagnosed as PCOS, or the patients are referred to us by the endocrinologist once they are diagnosed by PCOS for us to look after their cutaneous symptoms and signs. So the commonest is oily skin and scalp, acne, of course, hirsutism, androgenetic alopecia, darkening of the skin and acanthosis nigricans, which was mentioned by the earlier quiz, and unusual things like hidradenitis suppurativa, where we investigate and find that they have PCOS. So seborrhea is the earliest sign we can see in hyperandrogenism. And for the androgens to be effective on the sebaceous glands, we have to have your PPARs, because that is how it starts the combination. It causes mitogenesis, it causes hyperplasia of the sebaceous glands, and the secretions are modified in not only quality and quantity. And because of the excessive secretion, there's inflammation and there's disruption of the skin barrier, and there's hyperreactivity to the Malassezia furfur, which is a yeast organism. And you can see besides the acne, there are tiny micropapules all over, which give you a clue that this is a fungal infection in addition. Women also come to us with excessive greasy hair, and the more they wash, it gets greasier and greasier. So these are two things which we see very commonly with hyperandrogenism, and it's seen with polycystic ovarian syndrome. Hirsutism is something which is very troublesome. Of course, we know it's not a disease, it's more a sign. And it occurs in 5 to 10% of women in the reproductive age. And there are so many women walking around with hirsutism. And in the US, they account for $1.5 billion spent annually on hair removal products and procedures. And we have Dr. Aparna Santanam, who's going to talk to us about the procedures. So in hirsutism, we do have the excessive facial hair in the body sites, which have a male-like distribution. We know that PCOS is the commonest cause for hirsutism, and 70% of women with hirsutism have PCOS. And the clinical manifestations can be associated with the other associations of hyperandrogenism. But of course, we have to rule out the other conditions which can also cause hirsutism. And again, in the quiz, it was mentioned that you can have tumors, you can have drugs causing hirsutism, etc., etc. When we look at how do we get hirsutism, so when we are young, as children, we have vellus hair, which are non-pigmented, soft and short. But during adolescence, under the influence of androgens, that is testosterone and dihydrotestosterone, the vellus hair are converted to terminal hairs. And these are mainly in areas of the body that are androgen sensitive. It is also well established that hirsute women have increased activity of 5-alpha reductase in their hair follicles. And this enzymatic activity is also stimulated by insulin and insulin-like growth factor, which is part and parcel also of PCOS. This was discussed in the quiz. As dermatologists, we really don't use the FG scale because it's too bothersome, we use clinical photographs which show the comparison of as the treatment is going on. So this is not very common. It's only if somebody is doing a thesis, they're going to use it. The patients with PCOS who come to us, or the patients who come without being diagnosed, may come as with very mild. So you can see these sort of hairs are really not very terminal hairs, but they are the intermediate hairs, which are not as light as vellus hairs and not as dark as the terminal hairs. So the ones on the sides of the cheek are intermediate hair. You may have the thick terminal hair here, and you can have this sort of thing in a familial sort of hirsutism, which happens where you can have no cause. It just runs in families. But this is the way the patients really present to us with hirsutism. This young girl she waxes her chin every week, and this is a growth of a week. So if I allowed her to not wax for a period of 1 month, this would be almost like a man's beard. So this is the extent of hirsutism they come with. Also, you can have hirsutism associated with acanthosis nigricans. So you have the syndromal cases, and this was a young pubertal obese girl with acanthosis and severe acanthosis nigricans and hirsutism. And she came not because of her acanthosis nigricans or anything. She just said that my hair is getting dark and my complexion is getting dark. How do we treat hirsutism? Of course, you all know the medical treatment of hirsutism, but in all the management of hirsutism, if we look at the reports, there's a very low level of evidence onto the success of these treatments, medical treatments for hirsutism. The response of spironolactone equal to flutamide, and the studies have shown that the most positive responses we have seen is with the OCPs with cyproterone acetate. So even though we use spironolactone and we use flutamide sometimes, they have low level of evidence. In the mechanical hair removal, which has to go side by side with the medical management, we do have your temporary ones, which are plucking, waxing, threading, laser head reduction, which will be covered up later, or electrolysis, which was done in the past, which is not done now. Again, the questions we will take in the panel discussion. This is something which I want to still emphasize, that in certain cases which are not ready for who don't want to do the plucking, waxing, threading, or they are not ready for the lasers, it is worthwhile trying the topical eflornithine hydrochloride. There was a study which was done on 596 patients of hirsutism, and they were made to apply 13.9% eflornithine hydrochloride for 6 months, twice a day. And 58% of the women reported improvement in the facial hair, compared with only 34% of women on the placebo. The onset is slow, but over the months, over 4 to 6 months, you can actually see a reduction in the thickness. Acne is, of course, part and parcel of PCOS, and the prevalence in women with PCOS is estimated to be 10 to 34%. And these patients of PCOS will have a positive family history of acne. There are a lot of clinical presentations which come up to us. And if you look at these patients and you say, which of them has PCOS? Honestly, I would say the first number, because she has acne and hirsutism, but her acne is very mild. Or this patient who has the jawline acne, but when we investigate them, they may not have any PCOS. Now, if you look at this set of 3 patients, again, patient 1, almost all similar age. And if you look at them, everyone will say, oh, we know who has PCOS. It is the first case, because she not only has the very severe acne, which is almost nodular cystic, but she also has extensive hirsutism. This one may have had PCOS because she had scarring. So this is what's going on in your mind. But let me tell you who from these 3 actually had PCOS. It was this case, and she had PCOS, and when we investigated her ovaries were 24 cc's. both of them. And this was the one of PCOS. And when we investigated this one for PCOS, she definitely didn't have PCOS. She had no hyperandrogenism, which was, or hyperandrogenemia, sorry, to detect. We did everything, including her MRIs and everything, and she was labeled as end organ hypersensitivity. So, what is the characteristic of acne in the PCOS patients? Usually an adult onset acne, but we are seeing young PCOS. uh, can be on the face, chest, and back, so a larger distribution. We call this a V distribution. Typically, acne starts on the centrofacial, but in patients with hyperandrogenism, it is a V distribution, which is on the jawline, chin, and on the neck, upper neck. These patients do not respond to the typical anti-acne treatment, or if they respond, it relapses as soon as we stop it. Also, these patients complain of premenstrual flare. And if we look at the type of lesions, we are looking at mostly closed comedones and inflammatory. And I will show you the lesions. And of course, they would have accompanying signs of acanthosis nigricans, skin tags, obesity, alopecia, irregular, and all the rest. This is a case to show you that you can have extensive. Now, if you notice her face, please notice that it's really not very severe, her acne. But she had acne on extensive areas on her back, her full back. She had a mild amount of hirsutism on her upper lip, which she had waxed, and her chin. But the extension of the areas involved is one of the clues to look for a hormonal dysfunction. These are what we talk about when we talk about comedones. Comedones, we have closed comedones, which the lay people call blackheads, and which we have closed comedones, which are called whiteheads. These are the closed comedones, which are whiteheads. And in patients with hyperandrogenism, we see a lot of closed comedones. These comedones are not supposed to be taken to beauty parlors and removed with cleanups because they are not ready to come out. They are adherent to the walls of the follicle, and excessive manipulation can cause more inflammation or it can cause scarring. This is a typical V distribution, which is on the jawline and on the upper neck. Treatment of acne. So even if we have a patient who has PCOS with acne, we would do it in a traditional way. And only if they fail the traditional way, then we would go on to the other, like the anti-androgens or contraceptives, or even giving them isotretinoin. There are a lot of algorithms on how to treat acne, and this is a very simple algorithm. So when you go down the line of comedonal, you'll see that here, when it becomes a little more severe, the anti-androgens come into place. But notice that the other anti-acne traditional treatment is still going on. So in the mixed and the nodular and the severe, you're looking at isotretinoin or the anti-androgens. Also, a clue to hyperandrogenism in acne is that if you've given isotretinoin in the dose which is required to send them into a remission, and after we stop, the patient promptly relapses. Even if we are giving antibiotics, after several courses of antibiotics, the moment you stop, the patient relapses. This is a clue to look for, to hunt for hyperandrogenism. Alopecia. Previously, it was known as androgenetic alopecia, and now we call it female pattern hair loss. This is seen in patients with hyperandrogenism, or it's also seen in patients who, when we investigate, they do not have any hyperandrogenemia or even hyperandrogenism. So it is a non-scarring diffuse alopecia. And the most important thing to notice is there's a miniaturization of the hair, which I'll show you later. But the cause is that there is a reduction in the duration of the anagen phase, which is the growing phase, and a miniaturization of the dermal papilla, which causes thinning of the hair. And this affects the central, frontal, and parietal scalp regions. And although most patients with female pattern hair loss do not display other signs of hyperandrogenism, it may be associated with other conditions, the most common being the polycystic ovarian syndrome. And the important thing is that this is relentlessly progressive. And now we are seeing it in younger women. And when they come with their mothers, we see that they have a family history. It can be, there are various distributions and patterns of the alopecia. The typical, you can have how you have the Hamilton pattern, which is like how the male has, but these are the ones we commonly see: the Ludwig's classification, the Sinclair's classification, and the Oslin. In the Oslin, you see that when the thinning happens, it's almost like a Christmas tree pattern, which is very characteristic. And in the Ludwig's pattern, you see widening of the hair parting, and then you can see extensive involvement of the scalp. So these are the ways which we can categorize the loss. So I'm showing you some examples of how the kids come to us. And I'm seeing kids because now we are seeing them at 16 and 18. And of course, we are seeing older women who have completed their family thing and suddenly they decide, oh, it's time to look after themselves. So first thing you'll notice is a widening of the hair parting. That is the first clue. You can see recession of the frontal hairline, but this may also be contributed to the tight ponies which people wear. So it can be a combination of traction alopecia and the female pattern hair loss. You may have the typical male pattern with a temporal recession. And here you can see the widening. You can see that now you can see the scalp almost from here to here. This was a lady with typical Hamilton pattern of hyperandrogenism, and you can see she's thin just like a man. This is a lady who came when she was 45 and she said, oh, I want to do something for the hair, but you can see how advanced she was. And if you look at this slide, you'll see that the thick diameter of the hair has now reduced to very thin ones. And if you have more than 20% variation in in the hair diameter, plus you have gaps, you can see the gaps between the hair follicles, you have to think of a androgenetic alopecia, or we call it female pattern hair loss. And again, this was an 18-year-old girl. Can you imagine how much hair she's lost? And why did she not come earlier? Because she was giving her 10th and 12th standards. So her mother said that was more important. Now I have time to do her. So by this time they've reached very late. So it's always better to get them in early. So why does a frontal hairline remain in women? Because the frontal follicles have a higher level of aromatase, and studies suggest that women may have less severe hair loss than men due to lower levels of 5-alpha reductase and higher levels of aromatase in that frontal hairline. One study with 77 female subjects found that 48.6% of the women with female pattern hair loss also had metabolic syndrome. So now when we see patients with female pattern hair loss or males with female pattern hair loss, we have to investigate them for metabolic syndrome, or even explain to them in future that there's a high probability that they are going to get the metabolic syndrome. Possible mechanism to explain the association between these conditions are the presence of 5-alpha reductase and DHT receptors in the vessels. Treatment is currently in women, 2% minoxidil lotion and 5% minoxidil foam is the only FDA-approved modality in treating female pattern hair loss. All anti-androgenic agents are off-label. And we have now physical modalities like PRP and Regenera, which are very helpful in the patient. So this is how they respond to treatment. So you can see that with treatment, where you could see the scalp from right there to there, now you can see that there is almost a formation of a closer hairline. This was another patient who had severe thinning of the hair, and now you can see with treatment how she's responded. And it takes time. This was July and this is February. But if they are persistent with their treatment, they can get results. Acanthosis nigricans has been talked about in the quiz. And one must also know that the Acanthosis nigricans is characterized by brownish, grayish, pigmented, ripple-like pattern, commonly on the neck and axilla. But you can get it on the popliteal and cubital fossa. We have seen it in very obese adolescents and adults. The other sites can be the groins, the knuckles, the forehead, the malar areas, which we are seeing. We call this facial hypomelanosis, but it's actually acanthosis nigricans on the umbilicus or unusual sites. Of course, you know that metabolic disorders is very characterized by the acanthosis nigricans. And as I showed you earlier, PCOS. And here you can see she has a mild acanthosis nigricans on her. The cause of acanthosis nigricans is because of the hyperinsulinemia is able to reduce the IGF binding proteins 1 and 2, which regulate the levels of IGF. In addition, high levels of insulin increase the amount of circulating free IGF, which results in keratinocyte growth and differentiation. And it is likely the result of all this, the high levels of insulin binding to insulin-like growth factor 1 receptors on keratinocytes and fibroblasts. And this leads to a proliferation of both cell types and clinically apparent plaques and papillomatosis. Management of acanthosis nigricans, of course, it is multifactorial. Besides your metformins and other drugs, we can do to give them benefits. We can do topical treatments which tend to reduce the hyperplasia of the epidermis. We can give them retinoids. We can do peels. We can do dermabrasion, but these will not work unless they are also on the management of the insulin resistance. Pure dermat therapies that do not target the underlying condition are of transient benefits only. So this is not to be done as a routine unless you're giving the systemic therapy. This was interesting because we are seeing patients of hidradenitis suppurativa, which is an apocrine gland inflammation with follicular impediment. And there was a study done regarding hidradenitis suppurativa and comorbidities associated with it, and of which PCOS was the second most prevalent. So when we have patients, women with PCOS, with hidradenitis suppurativa, we also have to investigate them for PCOS. And the main etiology behind the hidradenitis suppurativa is insulin resistance and inflammation. So PCOS, seborrhea indicates sebaceous activity. PCOS is the commonest cause of hirsutism. Acne severity does not correlate well with the severity of PCOS, but a patient relapsing after several courses of antibiotics or after several courses of isotretinoin or with a premenstrual flare, even though their periods are regular, we have to think of PCOS. Acanthosis nigricans is a marker of insulin resistance, but other causes have to be ruled out. Female pattern hair loss has replaced androgenetic alopecia because although we see it in our patients, we may not have the hyperandrogenemia or other hyperandrogenism. And most cases, this I've already said. So this was in a nutshell, the cutaneous signs of PCOS. And the management of the hirsutisms and alopecia we can discuss in the panel discussion. Thank you very much for your patient listening.